My talk today is going to be about physical therapy after Chiari surgery with comorbid conditions, a unique pain management treatment, a manual therapy approach. Just the gist of this slide is that I'm a physical therapist in the United States and I'm osteopathically trained in Canada. So I look at my patients a little bit differently than the American physical therapist. I look at my patients from a biomechanical standpoint, and I set my treatment plans up from that as well. That's just my CV. This disclosure, I have nothing to disclose for this lecture at all. And all of my patients that I'm going to show pictures of today have signed waiver forms, so there are no HIPAA violations at all. Chiari signs and symptoms. Every patient is different. Just like all of our patients with different diagnoses, they have their own set of issues. However, our Chiari patients have common symptoms that are consistent, but their specific set of symptoms vary tremendously. Where some patients will have a large herniation and not have any symptoms at all, and some patients have a small herniation and have significant symptoms. This is a study that was done in 2004 of 265 patients by Mueller and Oro, and it indicated the common signs and symptoms of Chiari patients. And this was a great study from the standpoint that they were able to predict out of the 265 patients the percentage of the problems that each patient had. Also in that study, if I remember correctly, 50% of the patients had at least 5 of these signs or symptoms. So the biggest one was occipital headaches at 98%, vertigo at 84%, difficulty sleeping at 72%, weakness in the arms and legs at 69%, neck pain 67%, tingling and numbness in the hands at 62%, fatigue at 59%, nausea at 58%, shortness of breath and blurred vision at 57%, ringing in the ears or tinnitus at 56%, difficulty swallowing at 54%, and leg weakness at 52%. However, as a physical therapist, I'm not able to order MRIs or CAT scans or flexion extension tests. So when I do differential diagnoses with my patients, I have to understand the pathomechanics as well as some symptoms. So some clinical pearls when I'm looking at my patients, when I'm doing my initial evaluation, and that helps segregate out what's going on with them. I found these 3 things wrong with the majority of my Chiari patients. They have occipital headaches, but their occipital headaches are caused more often from coughing or sneezing or a Valsalva type activity, other than just a pure occipital headache with tight muscles. They have neck pain, and they have brisk reflexes. So when I'm sitting in the clinic and when I'm with my students or with some of my colleagues, when they can't figure out what's wrong with them, if they tell me they have these 3 things, I ask them to look into a Chiari malformation or have them call their neurologist or their orthopedist or their neurosurgeon and have them take a look at them if they have not. These are the comorbid that are associated with Chiari malformation that we've talked about all day today. Ehlers-Danlos syndrome, cranial-cervical instability, cervical spine instability, syringomyelia, tethered cord, dysautonomia, hydrocephalus, spina bifida, basilar invagination, scoliosis versus kyphosis. Now, if you go back a slide or 2, all of these signs and symptoms that are for your Chiari malformation are also the signs and symptoms of their comorbid conditions. So that's why I think it's difficult to just diagnose a patient from radiographic studies or diagnostic imaging. We really need to listen to what our patients are telling us clinically, what we're finding on them objectively in the clinic, and also on their diagnostic imaging, which will help us be more clear on what's wrong with the patient. Now this slide, I basically got off the Chiari Institute website for a successful Chiari surgery, and they have 3 successes: optimal decompression of the nerve tissue, reconstruction of the normal size cerebrospinal fluid space behind the cerebellum, restoration of the normal cerebrospinal fluid flow between the cranial and spinal compartments. However, it does not discuss successful outcomes. It just says from a diagnostic testing standpoint that the patient's surgery was successful. So if you take a look at it from an imaging standpoint, even though they may be complaining of pain or have some issues, everything looks normal on the MRI or on the CAT scan. We have to remember the majority of our patients, when they get CAT scans, they're lying supine when they're having it done, so it's a one-dimensional picture. They're not standing up against gravity. So that may have some issues when we're looking at a patient in a standing position. And I know Dr. Hennison and Dr. Bonanes uses functional testing where the patient's standing for their MRIs. So I'm wondering from Dr. Hennison and Dr. Bonanes if you've seen anything different when the patient's been standing versus supine. From a physical therapy standpoint, what my outcomes are dependent on from a patient is how are their posture? Is it proper? Is it incorrect? Their biomechanics of their neck, their thoracic spine, and their lumbosacral spine, and their sacroiliac joint, and do they have good habits? And obviously ordering proper physical therapy can be helpful. Not all physical therapy is helpful, as a lot of our patients will tell us when they're post-surgery. Muscle and ligament. Normal muscle function, muscle should always be off tension and only actively contract when we want it to. So I'm pressing this button to move my hand to show you that. I'm actively doing that. Our ligaments should always be on tension to support or stabilize our joints. However, in our EDS patients, or our Chiari patients, a lot of times their muscles are always on tension, which are attempting to stabilize the patient's joints. So they're not doing their job by actively moving things. They're actually co-stabilizing the joint so the joint doesn't move because the ligaments are off tension and not stabilizing the joint. And that causes a lot of problems. The results of this are when muscles are always on tension, it equals pain, muscle tightness, muscle spasms, trigger points, and eventually causes weakness. Ligaments, when they're always off tension, they'll cause joint pain from the bones sliding on each other, instability, supplications, or dislocations, which we see a lot of times in our EDS patients and our hypermobile patients. The goal of manual physical therapy is to reverse this process. We want to take the muscles off tension and try and get the ligaments on tension. Once we structurally have aligned our patient and have them balanced and they're having minimal pain, we start to do specific strengthening, stretching exercises for the muscles that are tight or the muscles that have been in spasm. We'll also start some therapeutic strengthening or toning exercises as well as some stabilization exercises to maintain the integrity of the position that we put them in. Now, these are some manual therapy and osteopathic treatment techniques that I utilize when I treat my patients. A direct technique is a mobilization versus a manipulation. An indirect technique is going in the direction of ease or in the direction of the dysfunction. Soft tissue massage and mobilization, lymphatic drainage, craniosacral therapy, facilitated positional release, functional techniques, myofascial release, ligament articular releases, muscle energy techniques, Jones strain, counter strain, and visceral manipulation. Osteopathy is built on these three principles by the founder of osteopathy. It was A.T. Stills, and he looked at the body as one unit. We have a lot of physical therapists and doctors that subspecialize in just the hand, just the shoulder. But when we're looking at our patients, we really need to look at the entire patient so that we can get the big picture, and then we can narrow it down to what's wrong with them. This is the most important aspect from a physical therapy standpoint and an osteopathic standpoint. Structure equals function. When our patient is not aligned correctly with a forward head posture, or they have increased scoliosis or lordosis or kyphosis, their body can't function correctly. So they'll have issues with their spine or with their extremities. So we need to make sure that we have the patient structurally aligned so that we can get them feeling better. And the body poses its own mechanism for repair and to restore health. Now, this is a good picture of good posture versus bad posture, where this patient is standing in a correct position with the head in the right position. They have a nice cervical lordosis, thoracic kyphosis, and a lumbar lordosis. Their center of gravity is right over S2, their sacrum and pelvis are level, and their shoulders are square. And the patients that come into my clinic pre-surgery and post-surgery, they usually look like this. So the doctor might have done, or the neurosurgeon or the orthopedic surgeon might have done a phenomenal surgery, and have good results with the success of the hardware, but if they come in with their head in a forward position, it's going to put a prolonged stretch on the anterior neck muscles. It's going to put a prolonged compression or shortening of the posterior cervical occipital muscles, and that's going to cause tightness. If you keep a muscle on prolonged stretch or a muscle on a prolonged contraction, they are going to fatigue and cause pain. As you can see, they're getting a little bit more kyphosis here, or potentially a scoliosis. The pelvis is tipping forward, which is going to increase the tightness of the hip flexors or the iliopsoas, and their quadriceps, which is going to increase their lumbar lordosis and give them back pain. So I want to do a demonstration with Dr. Henderson, if you wouldn't mind coming up here. We talked earlier about muscles after surgery, and I just want to give you a demonstration about how muscles work from a physical therapy standpoint. Put your glasses down. You don't have a disc injury or anything like that. Put your glasses down. Yeah. All right, stand up here. Put your hands down here. You're going to hold that up. Keep it straight, just the way your head would be. Now, this is a person in a normal position with their head square. How does that feel in your arms? Good. All right. Feeling any tension in your arms at all? Good. Because when you're standing up straight, there is really no pressure on your neck muscles or your back muscles because you're hanging out on your ligaments. Now, when we tilt the head forward about an inch, now hold it there. There's a tremendous amount of pressure. As you can see, it's slowly moving forward. Be careful it doesn't hit you in the groin. Now, my mom asked me before I did this presentation not to choose a woman because I can't ask a woman her age according to her weight according to my mother. But Dr. Henderson, is it fair to say that you weigh close to 200 pounds? A little over. All right, a little bit over. A normal patient's body weight in their head is 10%. So if he weighs 200 pounds, his head weighs 20. This case right here, that's a 10-pound weight. That's only half of the weight of Dr. Henderson's head. He can feel the pressure in his hands right now and the tightness in his muscles. So if you can imagine, take that away for a minute so you don't hurt yourself. Going back to this right here with the poor posture, the amount of pressure that he's putting on his neck is about 2 to 4 times the weight of his neck. So if his neck weighs 20 pounds, you're looking at 40 to 80 pounds of pressure per square inch on your neck with those muscles being tight. Now, if the patient comes into you pre-surgically and you do a beautiful surgery, and then after the surgery, they leave and they still have the same posture, they're still going to have pain. Now, the surgery may look beautiful on diagnostic testing, but when they come into my physical therapy clinic, they're in a lot of pain. And the pain is coming from their muscles or the imbalance in their muscles in their neck. Now, as we know, our suboccipital muscles attach to the base of our skull and go all the way down to our low back and our sacrum. So it's fair to say that if your head is forward long enough, it's going to eventually affect your mid-back and your low back. And that gets back to the principle of osteopathy, the first one, the body is a unit. We can't listen to our insurance companies when we come into therapy and they say, all right, Mike, you can only treat the patient's neck because they have a herniated disc at C5. But if their head is forward and they're getting low back pain, I need to look at the patient's whole spine and treat the whole spine. And again, getting back to structure equals function. Everybody stand up for a second. I know we've been sitting down for about 2 hours, so everybody stick your head forward. Just really bring your chin forward. How does that feel in the back of your neck? It doesn't feel so good, does it? Imagine you staying like that 24/7, 365 and a quarter. It's going to bother you. And that's what our patients look like coming into physical therapy. Now, when they come back to your office after neurosurgery, it's about a week later so you can change their dressing and take a look at the incision and stuff. And then after that, it's about a month, and then after that, it's a couple of months, 3 to 6 months, after then a year. They come into physical therapy 2 to 3 times a week, so I'm getting to see them on a much more regular basis, so I'm getting to see what's going on with them post-surgically. So that's kind of an important thing to understand and remember.
You want me to stay here?
No, you can sit down. Thank you. Now, getting into the forward head posture post-surgically, Dr. Liu mentioned this early this morning when he was giving his lecture about scar tissue. Now, potential results of poor posture post-op. Scar tissue issues, poor healing post-op. If your patient's in a forward head posture, you take a look at that scar tissue, it's not going to heal well. It may keloid, it may have bumps in it, or it may atrophy, depending on if they have Ehlers-Danlos or if they have any other comorbidities. Now, the foramen magnum may become smaller, not the opening itself, but it may get some compression on it from some of the soft tissue that's there or from some of the hardware that's placed in there if they keep a forward head posture, and that could actually compress some of the cerebrospinal fluid flow as well as the brainstem itself. You will definitely get neuroforaminal narrowing, which could cause nerve root compression. And if the patient has cranial cervical instability, cervical spine instability, Ehlers-Danlos syndrome, or a syringomyelia, these comorbidities post-op will also cause potentially poor outcomes. So we need to, again, look at the whole picture, not just one little piece of the picture. Now, this next picture is going to show you about scar tissue. This is a patient that had a decompression by Dr. Wang. As you can see, I have her in a nice neutral position, and she does have Ehlers-Danlos as well, hypermobile pot. And as you can see, her scar tissue with her head in a neutral position is nice and long. There's no bumps in it, and there's no bumps going into the scar going into her cranium. And I just had her separate out of here so you could actually see the scar itself. Now, when she goes into a forward head posture the way she was coming into my clinic, now take a look at the scar right there. It's bulging out. Look at the shortness of the scar here and how it's contracting on itself versus there. Now, this is a front view of her head being in the neutral position, so her chin's not too far forward, so you're not elongating the neck muscles in the front, and you're not shortening the muscles in the back. So she has a nice development of her scar, and she's getting a good lordosis in her neck. Side view with the forward head posture, as you can see her chin forward here, you can see the scar tissue shortening, and you can see it bulging out over here. So that could potentially lead to some problems post-op. Now, this is just getting back to the good posture versus the bad posture. And I'm going to show you on one of my patients who has poor posture. She has a scoliosis, as you can see from her shoulders, a forward head posture, and her head's rotated. She has a 5 millimeter cerebellar herniation. And she has a lot of the signs and symptoms of what I showed earlier on Mueller. This is her from the front view. As you can see, her chin's forward. She's getting a reversal of her lordosis. The more you keep your head forward, the more the muscles in the back of your neck tighten up. Therefore, you will get a reversal of your cervical lordosis or potentially a straightening of your cervical lordosis. Her thoracic spine has no kyphosis to it, and her lumbar spine has no lordosis to it. It's reversed. Now, putting her in the right position after doing exercises, you can see her shoulders are level now. Her head is straight. It's not off to the side. From the side view, you can see she has a nice lordosis in her neck, a little bit of a kyphosis here, and a little bit of a lordosis in her lumbar spine. And she's much happier, as you can see in the picture. She has less pain on her face. Now, she loves to go on the computer. A lot of my EDS patients and Chiari patients, we were talking about this at lunch, they love to do research. And when they come into the clinic, they come in with piles of paper saying, what's wrong with me, or why is this going on? She loves to be on the computer, and as you can see her on the computer, her chin's too far forward, shoulders are rounded up. It's putting a lot of compression in her neck and her back. And she's not sitting right in the chair with her feet either. So a simple technique is putting your fingers just under your nose on your maxillary and having them just do a gentle chin tuck, which will help them get their neck in the neutral position. I was taught in school to put your fingers on the mandible and push back. I don't like doing that because a lot of my Chiari patients and a lot of my EDS patients also have TMJ. So if they press too hard on the mandible, they could cause themselves some TMJ issues. So I just go a little bit superior and put it right on the maxillary. And as you can see from her posture on the next picture, she's sitting in a really nice position, and now she can type on the computer and work. The only thing I don't like about this picture is her feet are off the floor. This chair needs to probably be down about 1 inch. Then she'd be in perfect posture. Now, I'm just going to show you a manual physical therapy or an osteopathic treatment session with the patient. This patient that I'm going to be showing you is Nicole. This is a patient of Dr. Henderson's, and she had a Chiari malformation as well as Ehlers-Danlos syndrome and cranial cervical instability. And this is just a manual therapy treatment. I'm balancing off her sacroiliac joint and her ilium in this picture. In the previous picture, I'm working on her rib cage and balancing off her ribs and her shoulder. Again, her sacroiliac joint and her low back. I'm doing a diaphragm release here to help her back and her stomach. Doing a thoracic inlet release. and doing some relaxation techniques on her cranium. In this picture, I'm doing a cranial sacral balancing technique, so I'm putting the whole spine and having the whole spine work together. And this is her post-treatment pictures. This is before she did the treatment. This was after. And the treatment took about 20 or 30 minutes. And this is just one visit. So she came in looking like this. She left looking like that. This is the frontal view with the head tilted and her body leaning forward, her arm further out in front of her body, her head in a better position here and her shoulders square, and her hand here not as far forward as it is here. And this is another patient. This is actually a patient of Dr. Bowenase's. This is Ellen, and I'm doing a treatment for her lower body. She has issues with her legs. She has EDS as well as had a Chiari, and she's had a lot of other issues. I'm balancing off her tibia on her femur, balancing her patella, balancing her ankle, doing a treatment of her cuboid and her navicula. And this is how she looked before the treatment, and this is how she looked after. She would have to come in wearing this figure 8 brace, which we use for our patients with clavicular fractures to hold her shoulders back. Post-treatment, she didn't need it, and she doesn't use it anymore since we've been treating her. And I didn't treat her from the waist up. I treated her from the waist down, and this is how she still looked after the treatment. The side picture, before and after. These are some gentle stretching exercises. I know a lot of doctors with our Ehlers-Danlos patients say, don't stretch the patients because they're hypermobile. Well, that's true. They're hypermobile, but they have some muscles that are too tight that need to be stretched. Because if you don't, they're still going to have a forward head posture. In this picture, you can see she's holding onto her clavicle and she's tilting her head up, and she's getting a very nice stretch on her scalene muscles. As long as we don't go too far over, she's going to get a good stretch. This is an isometric exercise, and I know she's not having her fingers on her head to resist anything, but I found with my Chiari patients and my EDS patients, when they've had cervical fusions, you can't just start having them do these exercises because they're hypermobile in their shoulders and they dislocate their shoulders or their fingers. So what I started doing with these patients, as long as they're not having any occipital neuralgia, is I have them use their eyes. She's turning her eyes to the left, and as you can see, her right sternocleidomastoid is firing, which before that she couldn't do. So it's a nice way to start some therapeutic exercising or some stability exercising with the patients. This is a patient of Dr. Hennison's. She had a Chiari and EDS, and she had a Chiari malformation decompression. And I have her in a neck brace, and she's starting to do isometric exercises of her neck. As you can see, her anterior neck muscles are firing. She's doing a stabilization exercise for her neck in the front. And I have my patients start off in a neck brace so that I make sure that I'm not causing any issues with the surgery. And most of these patients will come to me about 3 or 4 weeks after surgery. They're not starting right away. And I don't start this on day one. I make sure they're aligned first before I start this. This is her doing it without the neck brace. As you can see, she's turning her head to the right this time, and she's really firing her left sternocleidomastoid, which is firing quite nicely. This is a young lady that is a full-size woman who is able to do core stabilization exercises now. Before this, she couldn't do any exercising at all. She was pretty much bedridden, and she's actually a nurse, and she couldn't work. Now she's back to working as a nurse 1 day a week, and she's able to do some strengthening exercises as well now. She's able to bridge, which she couldn't do before. She also had a tethered cord, Chiari, cranial cervical instability, dysautonomia, cranial cervical instability, POTS, Raynaud's, a couple of other things as well. Here she's firing and strengthening her quads using some weights. This is another young lady that I'm treating. She missed almost her whole junior year of high school, and then I started treating her, and she was able to graduate high school, and she actually was the #2 player on her tennis team in high school. Now she's a freshman in college. A lot of doctors with EDS tell us not to use resistance bands. I think that's a myth, because if you use the right resistance, it's going to really help stabilize her scapular muscles in the back here, her scapula stabilizes. And this is maybe a 3 to 5 pound resistance, and that's it. And this is Dr. Bowenase's patient. I also like my patients to do some cardiovascular workout as long as I'm not having any issues with orthostatic hypotension, or POTS. And this is the same patient in her neck brace doing light resistant training to stabilize her shoulders. I'm not having her lift her shoulders higher than 90 degrees because I don't want her to get any shoulder impingements. And she suffered from shoulder dislocations repetitively. And this patient has had 25 surgeries in the last 20 years. And this is the first year since we've been treating her. She has not had any surgeries for at least 1 year. She's doing quite well.
Just put her on the surgical table. She's dislocated just on the way.
Yeah. And this is a positioning that I like to put my patients in here so that they can actually exercise correctly and do some strengthening of her glutes and her low back muscles. And I like to teach my patients self-correction so they don't have to keep running in to see me every day or every week. This is self-correction for the sacroiliac joint. This is self-correction for the first rib. A lot of my EDS patients, Chiari patients, cervical instability patients have a first rib and second rib that's sublux. So we teach all of these patients how to fix their first and second ribs. And obviously with the Chiari malformation, they have a lot of proprioceptive coordination issues. This is a functional grid. Each line on this grid is a degree, 10 degrees, 20, 30, 40. And as I start out with the patients, I start closer to the smaller circle, and as they get better, they're able to move out further. And I'm using a gait belt to make sure she's balanced. And I have her walking on a 2x6, or a 2x8, I'm sorry, it's a 2x6 piece of wood, and she has to balance walking on that. I started her walking on this white line first, then she started balancing on here. This is a BAPS board, which helps with ankle proprioception, which will help her know where her foot is in space when she's walking so she doesn't keep subluxing or dislocating her ankle or spraining her ankle. I'm having her stand on a balanced cushion while we're playing catch with her, and she's catching it and throwing it, so she has to engage her entire core and her whole body while she's doing this exercise. Again, I have a gait belt on her so she doesn't fall and get hurt. I'm balancing her using her whole core here, where she's sitting on a ball, maintaining pelvic neutral, and lifting her arm. And obviously, I'm having her do some proprioceptive training with walking to make sure she doesn't lose her balance. She has significant issues with her balance with falling and tripping, and she has a 5mm herniation. And I'm having her pick up little ping pong balls and put them in this little basket. So she's actually working on bending over to be able to pick things up from the floor without hurting herself. This is a modified golfer's lift. You see a lot of golfers on the tour do that when they go to pick up their golf ball in the hole. This is a young man. The only thing I don't like about this picture is the therapist didn't have his shoes tied. And he's working on a Bosu ball, which is very difficult to challenge your balance. He's really engaging his core, his quad muscles, his hamstrings, his gastrocnemius muscles in the back. This is Maggie, our service dog, and she opens the door for one of our patients. And this is the end. Anybody have any questions? Yes.
I'd just like to get your opinion about Alexander technique methods and Feldenkrais as other methodologies.
They're both excellent techniques. They teach the patient how to move within their own posture and how to modify things so that they can do certain activities that they couldn't do before. So they both work extremely well. And I actually like both of them. But for Feldenkrais and for Alexander, you have to be certified, and it costs $10,000 to $20,000 to get certified in it. And it's not currently reimbursed by insurance companies.
What is your experience with craniosacral massage?
Craniosacral massage, I know there are two schools of thought from a neurosurgical standpoint. I went to the University of New England in Maine, which is NECOM, the New England College of Osteopathic Medicine, and I have my osteopathic Canadian degree from the Osteopathic School of Ontario. So I look at it from, there's two types. Some people believe the cranial bones move and some people don't. My experience with craniosacral therapy or craniosacral massage, the patients drastically decrease their headaches, and it drastically decreases a lot of tension on the back of their neck, and some research states that it helps improve their cranial cerebrospinal fluid flow. But I don't have any hard facts on that.
No, there's no hard facts. But the funky thing from the interesting was that the velocities predicted or postulated by the people doing craniosacral manipulations the cerebral fluid velocities are the same velocity we found intraoperatively with the closed Doppler on the CSF in patients after normalization of the camera. So at least that is not approved by far, but it's intriguing that we're talking about the same thing.
The biggest problem with craniosacral therapy, to be quite honest with you, Dr. Bolognese, is it's not just osteopaths and physical therapists that are performing craniosacral therapy, so there's no gold standard. There's a lot of massage therapists and some personal trainers, they take one class and they throw a shingle up saying that they're a craniosacral therapist. So the results that you get with those individuals who don't really understand the anatomy and the physiology well doesn't work well. So it kind of gives craniosacral therapy a bad name. The therapists and the physicians or osteopaths that are highly trained in craniosacral therapy, their results tend to be better.
From Dr. Kula.
Could you just say a word about Atlas orthogonists and how that approach is effective or not? Atlas orthogonists.
Fogginess?
No, Atlas orthogonists. There's a school of thought among some osteopaths that there's some movement or manipulation that can move the atlas and improve craniocervical instability. And I have trouble understanding exactly what that is.
What I believe what they're looking at is when C1 is out of alignment or C2 is out of alignment, they put C1 and C2 back in place and the patient's energy level increases. Their foggy headness decreases. I actually teach my patients a self-correction for C1. And there's a treatment technique that I do to balance C1 without a manipulation. It's just a gentle mobilization. And the majority of my patients, when I do that on them, their lightheadedness, their foggy brain symptoms decrease. Now, when they go to get up, within a couple of hours from gravity pulling on their neck, the foggy headness returns, the lethargicness returns, and their energy levels start to drop.
Does that again have to do with the forward head?
I believe it does, but I also believe it has to do with their C1 going out of alignment. And as your head comes forward too much, you're getting a compression in the back of your skull, and you're getting an elongation in the front of your neck. Now, one could postulate that with that stretching too much, you could be getting a kinking in your vertebral arteries, which is causing some decreased oxygenation to the brain. And also with the head being too far forward, one could also potentially postulate that you're getting a decreased outflow through the jugulars, through the occipital mastoidal sutures when their head's too far forward with the muscles being compressed too much in the back of the neck. So, but I'm not sure from a pure theory standpoint.
Thank you. You'll be very pleased to see that as a casual observer, I think I noticed that the posture of the audience has improved remarkably over the course of the last half hour.